Welcome old friends and new friends. I'm Jody Hyman. I'm Dean of the School of Public Health. For those who are new friends here, it's fantastic to see you all here. It's a really important event tonight. I mean, every single time we have the Torrens Health Forum, the topics are important. I can't think of a more important moment, though. The global recognition of health as a fundamental human right is universally accepted. And recently in the United States, it's not only accepted, but we have begun to realize that notion of health as a universal right. And of course, there are many parts of health. There's public health, there's health promotion and prevention, there's social determinants of health and how discrimination in the environment and our working conditions and income all affect our health. But a crucial part is access to quality, affordable health care. And the appeal, really, that I want to make to all of you tonight is, as you're listening, think about how you want to act. This is our country. These are issues that are up in the air. It is not yet decided what will happen. And while I realize that in the audience we may have a real large range of views of the best way to make it happen, I think there's probably a lot of consensus that we should ensure that every single person has their right to health realized and has access to health. And what each and every one of us does, and what we urge all of our friends and families and peers to do over the next few weeks and few months, is going to shape what happens in the United States for that. So it is my great honor to kick off a panel that will hopefully help give us more information and more knowledge on which we can all base a way to act and exercise our democratic, and for those of us in healthcare, our healthcare responsibilities to our fellow people living in every single community in this country. So it's my joy to introduce Jack Dingelman, who I think everybody knows, who's chair of the Department of Health Policy and Management, distinguished academician himself, National Academy of Medicine member, and here to introduce the panel. Thanks very much.
Thank you, Jody. As you said, this is an important topic and an important issue. As we began talking about this, there were two things that were very clear that were happening. One is everybody wanted to talk about what's going to in healthcare management, public health policy, wanted to talk about what's going to happen to the Affordable Care Act in the new administration and with the new Congress. And on the other hand, everybody knew it was too soon to have that conversation. So we really spent some time thinking about what would be valuable right now. And we came to two recognitions of that. One is, if keeping with the Dean's spirit of it's time to think about what actions to take, we noticed among a number of our colleagues and friends in academia, in healthcare delivery, and healthcare payment, a certain deer in the headlights capture in this environment, just not knowing even what to do or even how to start doing it. And we were very eager to move past that to think about the options that people should begin and the way in which people were beginning to think about what choices they had and how to begin shaping their futures as well as responding to it. So with that, we said, we don't expect anybody to have definitive plans because there's no definitive change that's there. But let's talk to a couple of people who have been heavily affected by the creation of the ACA, folks who are in the financing health insurance business, and folks who are in the safety net delivery business, talk about how they're thinking about what they have to do and how they've gotten started acting. So that's the genesis for this session. And we've got a terrific panel to do it, and I'll introduce them in a moment. Apparently my slide is not there. Okay, but to set us up for that, I just want to remind us of the full scope of the Affordable Care Act. And since the rubric that the Republicans became elected on and that Donald Trump became elected on was repeal and replace, I want to talk about the full scope of things and how easy or hard it is to repeal or replace it. This week got a new twist to it because of the executive order that Donald Trump signed on on Monday, basically providing guidance to the Secretary of Health and Human Services and other agencies involved in setting regulations, policy, guidelines, waivers to basically give them guidance that any place where you have discretion in the bill or discretion in the regulations to make it easier for folks to do less because it will cost them something to do more, you have the authority to do less. So we've got the regulatory and guideline and waiver processes as one vehicle for not repealing and replacing, but at least modifying the behavior of the act. We also have the legislative process. And the bulk of the bill was passed under normal legislation, and then fixes were made under a reconciliation bill. So there's a tendency to think that the whole bill can get amended or repealed through reconciliation. Now, if you believe the rules that are in place about reconciliation will remain in place during the repeal and replace phenomenon, there are limits to that. Technically, reconciliation can only affect things that involve either government spending or government taxing. And anything else needs to be done through normal legislation. What I've got here is the list of some of the key provisions, very short. The list actually should be longer, but I didn't want to fully fill. But we can see that the act affected insurance availability through Medicaid expansion, individual insurance mandates with subsidies. That's a tax penalty if you don't buy the insurance. A small employer mandate implemented through a tax penalty. A large employer mandate. Insurance market reform with federally financed exchanges, that's spending. But guaranteed issue, no pre-existing conditions. That's not spending, and it's not taxing. That's just law that governs the way insurance companies do their business. Technically, should not be subject to reconciliation. No lifetime caps, modified community rating, essential health benefits, which are stated in the law and then specified in regulation. So possible area for regulation, but not reconciliation. Children under 26 on their parents' policies. A lot of Medicare reform. And because Medicare reform always involves federal spending or taxing, lots of opportunities there to modify what the law says about Medicare, including the advantages that have been made available to a large number of seniors, many of whom were part of the Trump constituency. A whole variety of taxing and financing strategies for making the bill work and to support the subsidies, all of which are potentially subject to action under reconciliation. So that's a quick view of the landscape of what the Affordable Care Act is and the areas in which possible change can be made. We do not know what the full scope of repeal, replace, or change the regulations are going to be, but we want to think about how the delivery system that serves the newly insured, how the insurance systems that serve the newly insured are responding to the uncertainty and the threat of change in these programs and cutbacks from the current coverage and payment. To do that, we've put together a terrific panel tonight. One, to help us better understand the political environment. Somebody who's been talking to people in Washington regularly about this is Mark Peterson, who's a professor of public policy, political science, and law, and chair of the Department of Public Policy in the UCLA Luskin School of Public Affairs. Mark's scholarship on presidential decision-making, congressional decision-making, public opinion, interest groups, has been phenomenal. Beyond that, he also has spent time on the ground in Washington as a legislative assistant to former Senator Tom Daschle on health care. So he brings both the admissions insight to this and the practitioner's insight. To help us understand the health insurance industry's perspective on what they think is going to go on and how they're anticipating and trying to plan for it and think about what might be going on, we have John Backus, who has 30 years of healthcare experience, having served in a number of executive positions in a number of insurance companies around the country, including Group Health in New York, which, as a New Yorker, I have real fondness for, and Kaiser Permanente's Northeast Division, also in New York. He is currently the Chief Executive Officer of LA Care Health Plan, the nation's largest publicly operated health plan serving 2 million members, many of whom have been covered only because of the new provisions of the ACA. To help us understand the safety net perspective, but somebody who also brings a broader perspective to the issue, we have Elaine Batchelor, who's the CEO of the Martin Luther King Community Hospital, which she rightly and proudly describes as the new state-of-the-art private nonprofit safety net, opened in 2015. Very excited to see that and what's going on. We'll get you here for another occasion, talk about what opening that up has been like and lessons learned for other safety nets. But before that, she previously served as the Chief Medical Officer of LA Care. So she's also been on the insurance side and was Vice President of Healthcare Finance, Organization, and Operations of the California Healthcare Foundation. That's the one in the northern part of the state that apparently does good work. So with that, we've got a great panel for this. We started out with this very formal, tell us about your contingency planning, and we made that a lot softer because of the uncertainty about what contingency planning even looks like in this environment. And I'm absolutely fascinated to hear how they're thinking about their changing environment and how they're trying to proactively react to it. So Mark, we're going to start with you.